Welcome to part one of our Ultimate Patient Assessment Masterclass. I'm Michael Melendez Camacho, and I'll be your lead instructor for this comprehensive deep dive. This workbook, derived from Egan's Fundamentals and the latest NBRC test banks, is your definitive roadmap for the TMC and clinical simulation exams. Over the next 30 minutes, we are going to dissect the bedrock of clinical assessment. We start with the critical life functions, the hierarchy of survival that determines every action in a crisis. Then, we'll move through the meticulous process of record review and the art of the bedside interview. Finally, we will master the physical examination using the IPPA sequence: inspection, palpation, percussion, and auscultation. This foundation is what separates a technician from a clinician. Let's get to work. We open with Section 1, Assessment of a Patient. In the high-stakes environment of the ICU or ER, you don't have time to second-guess. You must have a systematic, reflexive approach to evaluating your patient. This begins with the 4 critical life functions. These aren't just concepts, they are the physiological pillars of life. If even one of these is compromised, your patient is in immediate, life-threatening danger. We assess them in a specific, prioritized order to ensure we never miss the most lethal threat. The hierarchy of survival is your clinical compass: ventilation, oxygenation, circulation, and perfusion. Ventilation is the simple movement of gas in and out of the lungs, the clearance of CO2. Oxygenation is the successful loading of that oxygen onto the hemoglobin for delivery. Circulation is the heart, acting as the pump, moving that blood forward. And perfusion is the final destination, the actual flow of blood to the vital organs and tissue beds. You must internalize this sequence. If the pump is broken, but they aren't breathing, you fix the breathing first. That is the VOCP rule. Ventilation is always, without exception, your first priority. On the NBRC exam, you will encounter numerous scenarios where multiple things are going wrong. The board tip here is vital. Without an open airway and adequate ventilation, nothing else can be corrected. You cannot oxygenate a patient whose airway is obstructed or who isn't moving gas. Airway and breathing always come before oxygenation and circulation. This is the AB before C. If the CO2 is rising and the patient is failing to move air, that is your primary target for intervention. So, how do we measure ventilation at the bedside? We look at the respiratory rate, the depth of each breath, and the overall pattern. We look for the symmetry of chest movement. Are both sides rising together? We measure objective volumes like tidal volume, vital capacity, and the negative inspiratory force. But if you want the gold standard, you look at the PaCO2 from the arterial blood gas. The PaCO2 is the single best indicator of ventilation. If that number is climbing above 50 with a falling pH, your patient is in acute ventilatory failure. Period. Once ventilation is stable, we move to oxygenation. We monitor the PaO2 and the SpO2. On room air, a PaO2 less than 80 is abnormal, but once it drops below 60, you are dealing with severe hypoxemia. Look for the early warning signs. The patient becomes tachycardic and tachypneic, but pay closest attention to their mental state. Restlessness, anxiety, or an altered sensorium are often the very first signs that the brain isn't getting enough oxygen. If they're agitated, don't just sedate them. Check their oxygenation status first. It is a common clinical mistake to use circulation and perfusion interchangeably, but you must distinguish them. Circulation is the macro view. It's about the heart and the major vessels. We assess it through heart rate, rhythm, and blood pressure. Perfusion is the micro view. It's about the delivery at the cellular level. Is the blood actually reaching the brain, the kidneys, and the skin? A patient can have a normal blood pressure but still be poorly perfused if they are in compensatory shock. We have to look deeper than just the monitor. Identifying inadequate perfusion early can save a life. Look for cool, clammy, or mottled skin. That's the body shunting blood away from the periphery to protect the core. Check the capillary refill. If it's longer than 3 seconds, the microcirculation is failing. Monitor urine output religiously. Anything less than 20 to 30 milliliters per hour tells you the kidneys aren't being perfused. Finally, watch for metabolic acidosis and rising lactate levels. These are clear indicators that the tissues are starving for oxygen and switching to anaerobic metabolism. This is the definition of shock. We move now to Section 2, reviewing the patient's records. Think of this as your pre-flight checklist. A thorough, systematic chart review builds the clinical context you need. You aren't just looking for numbers, you're looking for a story. Why is this patient here today? What is their baseline? What has changed in the last 12 hours? The answers are in the record, but you have to know where to look. We start by distinguishing between the objective and the subjective, signs versus symptoms. Precision in terminology is non-negotiable for NBRC success. Signs are objective findings that you, the clinician, can see, hear, feel, or measure. A blood pressure of 88/50 is a sign. Cyanosis is a sign. Wheezing is a sign. Symptoms are subjective complaints reported by the patient. They cannot be measured, but they are equally important. When a patient says, "I feel like I can't catch my breath," that is a symptom. As a therapist, you must integrate both. You use the patient's symptoms to guide your physical exam, where you look for the objective signs to confirm the diagnosis. When you open that chart, there are 5 essential items you must examine. 1. The admitting diagnosis and the history of the present illness. 2. The patient's full history and physical. Don't miss their smoking history or occupational exposures. 3. The current physician orders and progress notes. 4. The medication record, including what they take at home. And 5. All diagnostic and lab results, ABGs, X-rays, and electrolytes. This review gives you the why behind the treatment plan. If you see a new order for a diuretic, you better be looking for signs of fluid overload in the record. We are often at the bedside during the most difficult moments of a patient's life, which is why understanding advance directives is so critical. A living will is a written statement describing what treatment a patient does or does not want. It does not name a decision maker. A durable power of attorney for healthcare is the legal appointment of a proxy to make those decisions. And then there's the DNR order, a specific physician's order directing that CPR and intubation not be performed. Our job is to advocate for the patient and ensure their wishes, as documented in the record, are followed to the letter. Every respiratory care order must be complete and properly written to be valid. There are 4 required components: the type of therapy or modality, the frequency and duration, the specific medication and its exact dosage, and the delivery device, or FiO2. If even one of these is missing, that order is incomplete. As a professional, you do not guess. You do not assume. You contact the physician, get the clarification, and document it. This isn't just about policy, it's about patient safety. Never give a medication if the order doesn't specify the dose and the diluent. Fluid balance is a window into the patient's hemodynamic status. We look at the intake and output over 24 hours. Normal urine output is about 40 milliliters per hour. If it's less than 20, you have inadequate renal perfusion. Watch for signs of fluid overload, peripheral edema, crackles in the lungs, and an increased CVP. Notice the laboratory findings too. Hemodilution from fluid overload will cause a drop in hemoglobin, hematocrit, and electrolytes. If the heart can't handle the volume, it will back up into the lungs. That is the beginning of pulmonary edema. We move into Section 3, bedside interview and medical history. This is where you establish rapport and gather the subjective data that drives your care. But you're also performing a clinical assessment from the moment you walk in the door. You're observing their level of consciousness, their ability to follow commands, and their overall emotional state. Are they calm and cooperative, or are they struggling for every breath? The interview is an active assessment tool. We start with the most critical metric, their neurological status. You must accurately document the level of consciousness. A lethargic patient is sleepy but arouses easily to voice. An obtunded patient is difficult to arouse and responds slowly. As they descend into stupor or coma, the risk to their airway increases exponentially. Remember, an altered sensorium is often the first clinical sign of a primary respiratory problem. Hypoxemia, hypercapnia, and acid-base disturbances all cloud the mind. If your patient is suddenly confused, don't assume it's dementia. Check their gas exchange first. This is a common board question and a vital bedside skill. We use the CATS Index of Independence in Activities of Daily Living, or ADLs, to judge a patient's functional status. Can they bathe, dress, and feed themselves? Can they transfer from a bed to a chair? Why does a respiratory therapist care about this? Because it determines their home care needs and their ability to manage their own respiratory equipment. If a patient can't perform basic ADLs, they aren't going to be able to manage a complex home ventilator or oxygen setup. We are looking at the whole person, not just the lungs. Let's define the subjective symptoms you'll encounter. Orthopnea is the classic sign of CHF or severe COPD. It's the inability to breathe comfortably while lying flat. We quantify it by asking, how many pillows do you sleep on? General malaise is that vague feeling of being run down. Dyspnea is the subjective sensation of shortness of breath. And never ever ignore dysphagia or difficulty swallowing. It is a massive aspiration risk. If a patient is coughing while they eat or drink, you must advocate for a barium swallow study immediately to protect their airway. Nutrition is the fuel for the respiratory pump. When we see muscle wasting or cachexia, we know the patient is in a catabolic state. Malnutrition is a classic, high-yield cause of failure to wean from the ventilator. Why? Because the diaphragm is a muscle, and if the patient is starved of protein and calories, the diaphragm will atrophy just like any other muscle. We also have to be careful not to overfeed with carbohydrates, as that increases CO2 production and makes weaning even harder. Nutrition and respiratory care are inseparable in the ICU. Section 4. Assessment by inspection. This is where you develop your clinical eyes. Inspection is the act of looking at the patient to gather evidence of their condition. We are looking for things like peripheral edema, digital clubbing, and venous distension. These findings are often the first clues to a systemic problem. A skilled therapist can walk into a room and just by looking, have a strong suspicion of what's going on with the heart and the lungs. Let's look at the specifics. Look for peripheral edema in the ankles and sacrum. If it pits when you press it, you're looking at fluid overload or heart failure. In liver failure, we see ascites, fluid in the abdominal cavity that pushes the diaphragm up and makes breathing even harder. And then there's JVD, jugular venous distension. If the neck veins are engorged with the patient at a 45-degree angle, that's a hallmark of right heart failure, cor pulmonale, or a life-threatening tension pneumothorax. These are all signs that the right side of the heart is struggling against high pressures. Digital clubbing is a slow, painless process where the nail beds lose their angle. It is a definitive sign of chronic hypoxemia, seen in cystic fibrosis, lung cancer, and bronchiectasis. We also check capillary refill if it takes longer than 3 seconds for color to return. Perfusion is poor. This could mean shock, hypovolemia, or heart failure. And look for diaphoresis, profuse sweating. It's a sign of severe respiratory distress, a myocardial infarction, or acute hypoxia. Your eyes are your first diagnostic tool. Skin color provides immediate feedback on oxygenation and perfusion. Ashen or pallor means the patient is vasoconstricted or severely anemic. Cyanosis, that blue tint, is the classic sign of hypoxemia. But here is an NBRC board tip. You need at least 5 grams of reduced hemoglobin to see cyanosis. This means a severely anemic patient can be dying of hypoxia and still look pink. Central cyanosis of the lips and tongue is always more significant than peripheral cyanosis of the fingers. If the core is blue, the patient is in crisis. Period. Observe the chest configuration. A barrel chest tells you the patient has been trapping air for a long time. Think COPD and emphysema. Kyphoscoliosis creates a restrictive defect that severely limits lung volumes. And always check for symmetrical chest movement. Both sides should rise and fall together. If they don't, if one side is lagging, you have to think about a pneumothorax, a collapsed lung, or even a right mainstem intubation, where only the right side is being ventilated. This is a critical safety check after every intubation. Breathing patterns are diagnostic fingerprints. Cheney-Stokes, the crescendo-decrescendo pattern with apnea, is seen in CHF and increased ICP. Biotz is an irregular pattern of deep breaths and apnea, signaling CNS damage. Kussmaul's is the body's emergency response to metabolic acidosis, deep and rapid breaths to blow off CO2. And don't forget apneustic breathing, a long inspiratory hold that tells you the brainstem is damaged. If the pattern is abnormal, the underlying cause is likely serious. Pay attention to the rate and the rhythm. Before we ever attempt to intubate, we must assess the airway. We look for swelling, secretions, and foreign bodies. We use the Malampati score to predict how difficult the intubation will be. Class 1 is a clear view of the soft palate and pillars. Class 4 is when you can't see anything but the hard palate. Remember, a Class 3 or 4 Malampati is a difficult airway flag. This means you need your glide scope, your fiber optic bronchoscope, and your most experienced clinician at the bedside. Don't be caught by surprise by a difficult airway. Section 5. Assessment by palpation. Now we use our hands to verify what we've seen. We check the pulse, feel for tracheal deviation, and assess tactile fremitus. Tachycardia, a heart rate over 100, is the first sign of hypoxemia that you must rule out. Bradycardia is late and ominous. We also look for a paradoxical pulse, a significant drop in blood pressure during inspiration, which is a hallmark of status asthmaticus and cardiac tamponade. Your hands are an extension of your assessment. Tracheal deviation is one of the most important findings on palpation. Here is the NBRC memory hook you must know. Things that take space away, like atelectasis, fibrosis, or a pneumonectomy. Pull the trachea toward the affected side. Things that take up space, like a tension pneumothorax, a large pleural effusion, or a massive tumor, push the trachea away toward the normal side. If you feel that trachea shifting, you know exactly what kind of pathology you're dealing with before the X-ray even arrives. It's a definitive clinical sign. Tactile fremitus is the vibration felt on the chest wall when the patient speaks. Increased fremitus means increased density. Think pneumonia or consolidation. Decreased fremitus means there's air or fluid in the way, like a pneumothorax or pleural effusion. And always be on the lookout for crepitus. That Rice Krispie crunch of subcutaneous emphysema is a sign that air is leaking out of the lungs and into the tissue. It's common after barotrauma or chest tube insertion. If you feel it, you better be checking for a pneumothorax. Section 6. Assessment by percussion. Think of this as sonar for the chest. By tapping on the chest wall, we generate sounds that tell us about the density of the underlying lung. Is it filled with air, fluid, or solid tissue? A skilled therapist can use percussion to map out the borders of a pleural effusion or identify the presence of air trapping. It's a fundamental physical exam skill that complements everything we've done so far. Let's look at the 4 specific notes you need to master for the board exam. We are looking for 4 specific notes. Resonant is the normal, hollow sound of air-filled lung. Flat and dull notes indicate increased density, like massive atelectasis, pneumonia, or a pleural effusion. Tympanic and hyperresonant notes mean there is far too much air, which is what we hear in emphysema, asthma, or a large pneumothorax. Here's the key. If you hear hyperresonance on one side, you're thinking air trapping or pneumothorax. If it's dull, you're thinking fluid or collapse. It's that simple. Here is your absolute board tip for percussion. Increased air equals increased resonance. If the lungs are overinflated, like in COPD, you will hear hyperresonance. If there is fluid or solid tissue where air should be, like in pneumonia or an effusion, you will hear a dull or flat note. Memorize this relationship. It will help you differentiate between a pleural effusion and a pneumothorax in seconds at the bedside. This is high-yield data for both the TMC and the clinical simulation exam. Master this grid. Finally, Section 7, Assessment by Auscultation. This is the hallmark of the respiratory therapist. We aren't just listening for breath sounds, we are listening for the movement of air through the entire tracheobronchial tree. We need to distinguish between the soft vesicular sounds of the periphery and the adventitious sounds that signal disease. Let's get our stethoscopes ready and talk about what we're listening for. We'll start with the basics of normal versus abnormal sounds. Vesicular breath sounds are normal. Anything else, crackles, wheezes, stridor, is adventitious and indicates pathology. Pay close attention to egophony, the E to A change. If a patient says E and you hear a nasal A through your stethoscope, that is a definitive sign of consolidation, like pneumonia. This happens because consolidated lung tissue transmits sound much better than air-filled lung. It is a classic clinical finding that will often appear on your exams. Listen for it over areas where you also hear dullness to percussion. In respiratory care, we don't just identify sounds, we link them to specific treatments. Coarse crackles mean large airway secretions. You need to suction or perform bronchial hygiene. Fine crackles mean collapsed alveoli or fluid. You think incentive spirometry, CPAP, or PEEP. Wheezing means bronchospasm. You give a bronchodilator. And stridor, that high-pitched crowing over the neck, is an upper airway obstruction that might require racemic epinephrine or even immediate reintubation. Your stethoscope tells you exactly what to do next. Don't ignore the heart while you're listening to the lungs. S1 and S2 are your normal lub-dub, but S3, the ventricular gallop, is a classic sign of heart failure or fluid overload. S4, the atrial gallop, suggests a stiff, non-compliant ventricle. We also monitor blood pressure closely. Hypotension is a sign of shock, decreased cardiac output, or vasodilation. A therapist who understands both the lungs and the heart is a master of the bedside. We have covered a massive amount of clinical material in this first half of our masterclass, from the 4 critical life functions to the complete IPPA sequence: inspection, palpation, percussion, and auscultation. These fundamentals are the foundation of everything you will do as a respiratory therapist. Master these physical exam skills, and you will be able to assess any patient in any condition with confidence. You are building the skills of a high-yield clinician. I am proud of the progress you've made today. Let's recap the most high-yield takeaways from Part 1. 1. Ventilation is always your first priority. 2. The PaCO2 is your definitive marker for ventilation status. 3. Remember your tracheal deviation hook, collapse pulls, tension pushes. 4. Always link your physical findings to a specific clinical action. These core concepts are the keys to NBRC success. Master the basics, and the advanced diagnostics will follow. You are doing the work, Michael, and it will pay off at the bedside and on the exam. In Part 2 of this masterclass series, we shift from the physical exam to the technological side of assessment. We'll dive into radiographic imaging, advanced imaging like CT and MRI, a comprehensive review of lab testing and cardiac enzymes, full ECG interpretation, and specialized assessment for our neonatal and pediatric patients. We'll finish the workbook together. I'll see you in Part 2 to complete your ultimate patient assessment training. Keep pushing forward. The goal is in sight.